Hello, health champions. Welcome to Wellness Wisdom, and please do remember to subscribe for more health tips. Liver cancer stands among the most complex and challenging malignancies faced by modern medicine. Despite its daunting prognosis in many cases, understanding this disease through the lenses of science, patient experience, and the ongoing innovations in therapy provides not only knowledge, but also hope. For many patients and clinicians, the fight against liver cancer is a relentless pursuit of time, truth, and transformation. The liver, being the largest internal organ, performs more than 500 vital functions, including detoxifying the blood, producing bile to digest fats, and storing essential nutrients. It's a resilient organ, often able to regenerate even after significant damage. However, when cancer takes root within it, that same resilience can mask early symptoms, delaying detection until the disease has advanced. The two main types of liver cancer are hepatocellular carcinoma, which arises from the primary liver cells known as hepatocytes, and intrahepatic cholangiocarcinoma, which originates in the bile ducts within the liver. Metastatic liver cancer, or secondary liver cancer, is more common and results from cancer spreading from other parts of the body, like the colon, pancreas, breast, or lungs. One of the preeminent institutions in the global fight against liver cancer is the Mayo Clinic, where Dr. Lewis Roberts, a renowned hepatologist and researcher, has dedicated decades to unraveling the molecular mechanisms of liver tumor formation. His team has worked on identifying genetic mutations and biomarkers that could not only detect liver cancer early, but also help predict a patient's response to certain treatments. Dr. Roberts emphasizes the interplay of risk factors that contribute to hepatocellular carcinoma, chronic hepatitis B and C infections, cirrhosis from alcohol abuse or non-alcoholic fatty liver disease, NAFLD, and exposure to aflatoxins in food. His work has underscored how hepatitis B virus integrates into the host genome, leading to mutations that drive cancer. In a 2019 publication in Nature Reviews Gastroenterology and Hepatology, Dr. Roberts described how the landscape of liver cancer in Africa and Asia is largely shaped by hepatitis B and dietary toxins, whereas in North America and Europe, rising obesity and metabolic syndrome are shifting the burden toward NAFLD-related hepatocellular carcinoma. These geographic differences are vital because they influence public health policies, screening practices, and treatment protocols. The Memorial Sloan Kettering Cancer Center in New York has been at the forefront of treating liver cancer with surgical and non-surgical interventions. Dr. Ghassan Abu Alfa, a leading oncologist there, has been instrumental in evaluating new chemotherapy agents and immunotherapy protocols for advanced liver cancer. His clinical trials have tested the efficacy of checkpoint inhibitors like nivolumab and pembrolizumab, drugs that work by unmasking cancer cells to the body's immune system. These immunotherapies offer hope to patients who cannot undergo surgery due to advanced disease or poor liver function. One such patient, who shared his journey through Sloan Kettering's public outreach initiative, was a 52-year-old former firefighter named Jason who had never thought of himself as vulnerable. Diagnosed with hepatocellular carcinoma after an incidental finding during a scan for abdominal pain, Jason underwent a combination of radiofrequency ablation and targeted therapy. His story, like many others, highlights the need for early detection, something the current medical landscape is striving to improve through biomarker discovery and imaging techniques. Another patient, Mariko, an immigrant from Japan now living in California, developed liver cancer following decades of hepatitis C infection acquired through a transfusion in her youth. She was treated at UCSF Medical Center under the care of Dr. Francis Yao, a transplant hepatologist known for his work in expanding liver transplant criteria to include more patients with liver cancer, using the so-called UCSF criteria. Transplantation remains the only curative treatment for certain liver cancer patients. The Milan criteria, developed in Italy in the 1990s, were initially the gold standard for determining transplant eligibility: a single tumor less than 5 centimeters, or up to 3 tumors, each less than 3 centimeters, with no vascular invasion. Dr. Yao's research demonstrated that patients slightly outside these parameters could still achieve comparable outcomes post-transplant, leading to broader criteria that increased access to this potentially life-saving option. Yet, organ shortage continues to be a major bottleneck. For every patient who receives a transplant, many others wait, or are removed from the waiting list as their disease progresses. Innovations like living donor liver transplantation, being advanced at centers like the University of Toronto and Mount Sinai in New York offer a promising alternative. Another domain where liver cancer management has evolved dramatically is diagnostic imaging. At Massachusetts General Hospital, radiologist Dr. Peter Muller has worked on refining the LI-RAD system, Liver Imaging Reporting and Data System, which classifies liver lesions seen on CT or MRI scans into categories based on the probability of cancer. This system is now widely used in North America and helps standardize decisions on whether to biopsy a lesion or proceed to treatment. As the medical community learns more about liver cancer, the boundaries between research and clinical practice continue to blur. Liquid biopsies, blood tests that detect circulating tumor DNA, are a hot topic in precision oncology. Studies from Stanford, Johns Hopkins, and the National Cancer Institute are exploring how early these assays can detect liver cancer, possibly even before imaging becomes positive. Beyond the lab, the psychological burden of liver cancer remains enormous. Dr. Jennifer Steele at the University of Pittsburgh has led numerous studies on the mental health of liver cancer patients, particularly those awaiting transplant. Her research highlights that depression and anxiety are common and significantly impact quality of life and survival. She advocates for integrating psycho-oncology into hepatology clinics, a model being increasingly adopted across cancer centers in the U.S. Patients face a dual threat: the physical progression of a deadly disease and the emotional toll of uncertainty. One family from Houston, Texas, whose father was treated at MD Anderson Cancer Center, spoke of the grueling ordeal. From the moment of diagnosis to the complexity of clinical trial enrollment and the challenge of navigating insurance. MD Anderson's Dr. Kanwal Raghav has contributed to this space by helping bridge clinical research and accessibility. His studies explore how socioeconomic and racial disparities influence outcomes in liver cancer. As treatment evolves, so too does prevention. The introduction of direct-acting antivirals for hepatitis C has significantly reduced liver cancer risk among cured patients, though not completely. Studies from the Veterans Affairs, or VA hospital system, including those led by Dr. Amit Singhal of UT Southwestern Medical Center in Dallas, show that even after successful HCV eradication, patients with cirrhosis remain at elevated risk. Hence, continued surveillance with ultrasound and AFP blood tests remains essential. Vaccination against hepatitis B has had perhaps the most significant public health impact in liver cancer prevention. Countries like Taiwan, which implemented universal HPV vaccination in the 1980s, have seen a dramatic decline in childhood liver cancer rates, a public health triumph widely recognized by the World Health Organization. In recent years, artificial intelligence has entered the fight. Machine learning algorithms trained on thousands of liver scans and clinical data points are being tested to predict tumor behavior and personalize therapy. A study from the University of California, Irvine used AI to predict which tumors would respond best to embolization, a procedure that blocks the blood supply to liver tumors. The promise of technology in reducing human error and standardizing diagnosis across health systems is immense, but still developing. Yet, technology must be paired with humanity. For Dr. Tanya Weltz at Charité University Hospital in Berlin, the art of medicine is in listening. Her practice involves narrative medicine, encouraging patients to share their stories not as data points, but as human beings whose identities extend beyond their illness. Each patient, each doctor, each scientist adds a thread to the intricate web that is liver cancer research and care. And while no single story or study can capture the full scope, together they form a mosaic of courage, persistence, and innovation. As we continue this journey, the next frontier lies in uncovering the molecular subtypes of liver cancer. Just as breast cancer is now treated according to its HER2 or hormone receptor status, researchers hope to one day categorize liver cancer with similar precision. Early efforts are underway. The Cancer Genome Atlas Project, spearheaded by the National Institutes of Health, has sequenced hundreds of liver tumors to identify actionable mutations. Drugs targeting FGFR mutations, Wnt signaling pathways, and MET amplifications are in various stages of clinical development. Personalized medicine is no longer a distant dream. It is arriving incrementally, one trial at a time. In the search for effective personalized treatments, oncologists have turned increasingly to genetic profiling. This involves sequencing a patient's tumor to uncover specific mutations. At the Dana-Farber Cancer Institute in Boston, Dr. Andrew Ju one of the foremost experts in liver cancer therapeutics, has emphasized the importance of genomic medicine. He led early trials exploring multi-kinase inhibitors such as sorafenib, one of the first targeted therapies to demonstrate a survival benefit in liver cancer. Though the benefit was modest, just a few months of extended survival, sorafenib marked a paradigm shift, proving that systemic therapy could have a meaningful impact. Dr. Ju and his colleagues have since explored other agents like lenvatinib, regorafenib, and cabozantinib, each targeting different growth factor receptors. These drugs have slightly varied efficacy profiles and side effect tolerability, leading to the emergence of treatment sequencing as a strategic decision. Physicians must weigh which drug to start with, how long to continue, when to switch, and what biomarkers might help guide those choices. Immunotherapy combinations have further complicated but also enriched this landscape. One of the most promising breakthroughs came with the IMbrave 150 study, which combined atezolizumab, a PD-L1 checkpoint inhibitor, with bevacizumab. This combination not only improved overall survival, but also improved quality of life compared to sorafenib. The trial, led by Dr. Richard Finn at UCLA, and presented at the American Society of Clinical Oncology, ASCO, was hailed as a milestone in liver cancer care. ASCO, one of the most influential oncology conferences globally, has been instrumental in disseminating liver cancer research. When the IMbrave 150 data were shared, oncologists across the world began shifting their first-line treatment preferences. The excitement was tangible, not just because of improved survival statistics, but because the treatment was tolerable enough to allow patients to maintain a semblance of normal life. Something particularly meaningful in a disease that often robs individuals of energy, appetite, and hope. Patient narratives help underscore the impact of these scientific advances. Elaine, a 61-year-old nurse from St. Louis, was diagnosed with advanced hepatocellular carcinoma. Deemed ineligible for surgery or transplant, she enrolled in an immunotherapy trial at the Siteman Cancer Center under Dr. Ramaswamy Govindan. She tolerated the combination well, experienced tumor shrinkage, and went on to enjoy 2 more birthdays, time with her grandchildren, and a renewed sense of purpose. Her story was shared in a patient spotlight video by the American Liver Foundation, which advocates for early detection and patient education. The American Liver Foundation, established in 1976, has become a central hub for patients seeking resources, guidance, and support. Its community outreach programs, including Ask the Experts webinars, liver wellness screenings, and caregiver support groups, have become critical for patients. Liver cancer survivorship poses unique challenges. Even after apparent cure through surgery, ablation, or transplantation, patients remain under vigilant surveillance. Recurrence rates can be as high as 70% within 5 years post-treatment. Managing this reality requires not only medical vigilance, but psychological resilience, and it is here that interdisciplinary care teams prove invaluable. At the Cleveland Clinic, a multidisciplinary tumor board meets weekly to discuss liver cancer cases in detail. These meetings include live reviews of imaging, pathology slides, and liver function tests, followed by robust debate over treatment options. Dr. Bassam Estefan, a medical oncologist at the Cleveland Clinic, has published extensively on optimizing systemic therapy and integrating new trial data into practice. Parallel to clinical care, the science of liver cancer prevention continues to evolve. Diet and lifestyle play critical roles. Research from the Harvard T.H. Chan School of Public Health has suggested that coffee consumption may be inversely related to liver cancer risk. Meanwhile, the global obesity epidemic has fueled the rise of non-alcoholic fatty liver disease and its more severe form, non-alcoholic steatohepatitis. In Japan, nationwide health check programs known as Ningen Doc include liver ultrasound and lab testing, leading to earlier detection. The World Health Organization has prioritized hepatitis elimination by 2030 as a major step toward cancer prevention. Several countries, including Egypt, have made extraordinary strides in hepatitis C elimination through mass testing and free treatment programs. In the realm of surgical innovation, centers like King's College Hospital in London have pioneered laparoscopic and robotic liver resections. The meticulous choreography of modern liver surgery, guided by 3D imaging, intraoperative ultrasound, and real-time navigation software, represents the height of precision medicine. Yet not all regions have access to such technology or expertise. In many parts of sub-Saharan Africa and Southeast Asia, liver cancer remains a death sentence. Organizations like Médecins Sans Frontières and the Global Liver Institute have begun initiatives to train local doctors and provide diagnostic equipment. Even in developed countries, disparities persist. African American, Hispanic, and Native American patients are less likely to receive curative liver cancer treatments. One of the most emotionally powerful accounts comes from the family of Eduardo, a second-generation Mexican American from San Antonio, Texas, who died of hepatocellular carcinoma at 58. His daughter Sophia, now a public health advocate, has since lobbied for mandatory liver health screening in primary care settings. As the battle against liver cancer advances on multiple fronts, one truth remains clear. The human liver, though powerful and regenerative, is vulnerable. New therapies continue to emerge. Bispecific T-cell engagers, cancer vaccines, and engineered T-cells are being tested in early-phase trials. Meanwhile, the next generation of hepatologists, oncologists, and researchers is being trained to think across disciplines. Conferences like the International Liver Congress and the Liver Cancer Summit bring together these minds from around the world, fostering collaboration that transcends borders. Every day in clinics and laboratories, the fight against liver cancer continues. Each patient represents not just a statistic, but a story, a family, a legacy, a future worth preserving. And while the road ahead is long, the progress made thus far is undeniable. In this shared struggle, hope remains the most powerful therapy of all. Hope, as it manifests in the lives of liver cancer patients, is not a naive optimism. It is often a hard-earned resolve forged through months or years of pain, uncertainty, and countless medical appointments. For many, that hope is sustained by the possibility of new trials and emerging therapies, the competence of a compassionate care team, and the will to live for loved ones. Title: The Journey of Hope in Liver Cancer. Among the most transformative advancements in recent years has been the refinement of loco-regional therapies, treatments delivered directly to the liver to shrink or control tumors without major surgery. These include transarterial chemoembolization, transarterial radioembolization, and radiofrequency or microwave ablation. At Johns Hopkins University, Dr. Jean-François Jeschwin was a pioneer in TASI and TARE, developing techniques that deliver chemotherapy or radioactive beads directly into the hepatic arteries supplying the tumor. This method maximizes cancer-killing effect while sparing surrounding healthy tissue. His research, widely cited in journals such as Radiology and Journal of Vascular and Interventional Radiology, helped standardize these procedures globally. Today, interventional radiology departments around the world continue to expand upon these techniques, using image-guided catheters and real-time perfusion monitoring to increase precision and minimize complications. One case that underscores the value of TACE involved an elderly patient, Mr. Anthony D., who was considered inoperable due to comorbid heart disease and compromised lung function. Treated at the University of Michigan's Rogel Cancer Center, Anthony underwent 3 rounds of TACE over the course of a year. The result: substantial tumor necrosis and stabilization of disease, granting him several years of functional life he would otherwise not have had. His oncologist, Dr. Monica Malik, noted that for certain patients, loco-regional therapy is not a stopgap, but a strategic, long-term disease management tool. Anthony lived to see his granddaughter's college graduation, something he once believed would be impossible. The convergence of artificial intelligence and interventional radiology is another promising frontier. Researchers at the University of California, San Diego are using machine learning algorithms to predict which patients will benefit most from TACE or TARE based on radiomic features, subtle textural patterns in imaging that are invisible to the human eye. These predictive models help clinicians select optimal therapy and monitor effectiveness, paving the way for more personalized interventions. In some centers, AI platforms have been integrated into multidisciplinary tumor boards, providing second opinion analyses that reduce variability in human interpretation. Alongside these innovations, the field of liver transplantation has also undergone substantial evolution. At the University of Pittsburgh Medical Center, a historically high-volume transplant center, protocols have been developed to perform salvage liver transplants, offering transplants to patients whose tumors recur after resection or locoregional therapy. These patients are carefully selected based on tumor biology, response to initial therapy, and overall performance status. Dr. Abhinav Humar, Chief of Transplantation at UPMC, argues that response to therapy is just as important as tumor size or number when assessing transplant eligibility. If a patient demonstrates a strong response to embolization or ablation, they are more likely to have favorable tumor biology and better post-transplant outcomes. Still, transplantation remains out of reach for many. Some patients are disqualified due to comorbidities, active substance use, or lack of social support. Others simply live in regions with limited access to transplant centers or face prohibitively long waiting times. To address these gaps, some countries and states have piloted regional organ-sharing networks and incentive systems for living donors. South Korea, for instance, has a high rate of living donor liver transplants, with families often stepping in to donate a portion of their liver. This cultural and structural support system enables more timely transplants and better long-term survival rates. Studies from Seoul National University Hospital have shown 5-year survival rates exceeding 80% for living donor liver transplant recipients with liver cancer, especially when done before tumor progression. The role of diet and metabolism in liver cancer progression is another area of intense research. At the Karolinska Institute in Sweden, Dr. Helena Nordenstedt has examined how insulin resistance and lipid dysregulation fuel liver cancer development, particularly in the context of NAFLD. Her epidemiological work indicates that metabolic syndrome may rival viral hepatitis as a risk factor in developed nations within the next 2 decades. Parallel basic science studies at the Broad Institute in Cambridge have shown that tumors arising in fatty livers have distinct metabolic signatures, including increased oxidative stress and altered mitochondrial function. Targeting these pathways with drugs like metformin or newer metabolic inhibitors could become a novel strategy for prevention or adjuvant therapy. Meanwhile, the psychological dimensions of liver cancer continue to gain recognition. At King's College London, Dr. Tricia Greenhalgh has advocated for narrative medicine and reflective practice in oncology, emphasizing that medical treatment alone is insufficient. Her work explores how listening deeply to patient stories can reveal not only symptom burdens, but existential concerns that are often overlooked in clinical metrics. For example, the loss of identity that accompanies liver cancer, particularly for those whose work, self-image, or community role revolved around vitality or caregiving, can lead to profound grief, even before death. Clinicians trained in narrative listening may better recognize these emotional inflections and refer patients to appropriate counseling or palliative care services earlier. Incorporating palliative care early, not only at end stage, has been shown to improve outcomes. The landmark TEMEL study in the New England Journal of Medicine, while originally focused on lung cancer, has influenced protocols across multiple cancer types. Institutions like Stanford and Duke now embed palliative care within oncology clinics, ensuring that patients' values, preferences, and symptoms are continuously addressed. For liver cancer, this is particularly critical due to complications like hepatic encephalopathy, ascites, and cachexia, all of which can drastically impair function and quality of life. Stories from palliative care units reveal the human side of this approach. One patient, Mr. Ravi Sharma, an engineer from Mumbai, India, spent his final months at Tata Memorial Hospital under the care of Dr. Marianne Mukherjee. Though treatment options had been exhausted, his palliative team helped him achieve goals of meaning, reconciling with estranged family, recording life lessons for his sons, and dying with dignity at home. His case became part of a training module for Indian palliative fellows and is a testament to the global need for compassionate end-of-life care. Technology, too, is now being leveraged to provide palliative support. Smartphone apps such as MyPal and PainBuddy, developed in Europe and the United States respectively, help patients log symptoms, receive medication reminders, and communicate more effectively with their healthcare team. These tools, while simple, bridge a critical communication gap and allow interventions to be made before symptoms escalate into emergencies. Pilot studies at the University of Toronto have shown that patients using these tools report higher satisfaction and fewer ER visits. The battle against liver cancer is fought on many fronts, not just in research laboratories or surgical theaters, but also across diverse global communities. In many low and middle-income countries, liver cancer presents an enormous burden, compounded by limited access to diagnostics, fragmented healthcare systems, and widespread prevalence of hepatitis B and C infections. The World Health Organization has repeatedly emphasized the urgency of scaling up hepatitis vaccination, treatment, and screening services as a global imperative, not only to combat liver disease, but also to prevent a cascade of cancer-related complications. Sub-Saharan Africa, for instance, continues to suffer from disproportionately high mortality rates associated with hepatocellular carcinoma. In many parts of Nigeria and Ghana, patients often present with advanced disease due to delayed diagnosis, social stigma surrounding cancer, or a lack of routine screening infrastructure. Dr. Nuhu Sani, a hepatologist at the University of Abuja Teaching Hospital, has advocated for integrating hepatitis B screening into maternal and child health services, where healthcare interactions already occur routinely. His vision is simple but profound. By embedding liver health in everyday care delivery, opportunities for early detection increase dramatically, even in resource-limited settings. Community health workers have also emerged as crucial allies in this fight. In rural Kenya, the AMPATH consortium, led by a collaboration between Moi University and Indiana University, has trained hundreds of lay health workers to educate communities about hepatitis transmission, offer rapid testing, and refer high-risk individuals for further care. Their efforts, coordinated by Dr. Sylvester Kemayo, are a model of grassroots public health, proving that progress is possible even where resources are scarce. Their real-world impact demonstrates that data collection, community engagement, and decentralization are as vital to liver cancer control as high-tech treatments. Moving to Asia, the scale of liver cancer in China remains staggering. The country accounts for over half of all new liver cancer cases globally each year, with major risk factors including chronic hepatitis B, aflatoxin exposure, and rapidly increasing rates of obesity. Yet, China has also made remarkable strides in both policy and innovation. The Chinese Liver Cancer Clinical Research Network, led by institutions like Fudan University and Peking Union Medical College Hospital, has orchestrated large multi-center trials that rival those in the West in both rigor and scope. One notable example is the RESCUE trial, which evaluated the use of camrelizumab, a PD-1 inhibitor developed domestically combined with VEGF inhibitors in patients with unresectable HCC. The results, published in The Lancet Oncology, demonstrated comparable efficacy to Western immunotherapy regimens with potential cost advantages. These trials are not only scientifically important, they are politically and economically strategic, laying the groundwork for more accessible therapies for China's massive population. In India, meanwhile, a different challenge emerges, balancing traditional medicine with modern oncology. The prevalence of Ayurvedic and homeopathic treatments for liver ailments often delays conventional diagnosis and therapy. However, integration models are being explored. At the All India Institute of Medical Sciences in New Delhi, Dr. Anupama Gupta is leading efforts to document the phytochemical properties of traditional herbs used in liver remedies and investigate their compatibility with chemotherapy. While caution is paramount, these integrative approaches may help bridge cultural divides and enhance patient trust. A rarely discussed but profoundly important subset of liver cancer occurs in children. Pediatric liver cancers are relatively uncommon, accounting for only 1 to 2% of childhood cancers globally, but their management is particularly complex. The most common form, hepatoblastoma, typically affects children under 5 years old. Unlike adult HCC, hepatoblastoma often responds well to chemotherapy and surgical resection, especially when diagnosed early. At St. Jude Children's Research Hospital, Dr. Andrew Davidoff has pioneered surgical approaches to complex hepatoblastoma cases, including multivisceral resections and even ex vivo liver surgery, where the organ is temporarily removed to facilitate tumor excision. St. Jude's survival rates for hepatoblastoma now exceed 85% in early-stage cases, setting a benchmark for other institutions worldwide. Collaborative groups like the Children's Oncology Group, COG, and Siopel in Europe, continue to refine risk stratification and chemotherapy protocols, ensuring that even rare cancers benefit from international knowledge sharing. Pediatric patients also highlight the emotional and social dimensions of cancer in a unique way. For families, a diagnosis of liver cancer in a young child is a shattering event that transforms every aspect of daily life. Support networks, such as Ronald McDonald Houses and Pediatric Cancer Foundations, provide critical psychosocial support, meals, accommodation, peer groups, that, though outside the hospital walls, are fundamental to treatment success. A mother whose son was treated at Boston Children's Hospital remarked, "It wasn't just the chemo or the surgery. It was the fact that someone brought us dinner after a 14-hour day that made us feel like we could survive this." As pediatric cases show, survivorship and long-term follow-up are also essential. Survivors of childhood liver cancer are at risk of late effects, such as hearing loss from cisplatin chemotherapy, growth abnormalities, and liver dysfunction. Transitioning these children into adult care involves coordinated efforts between pediatric oncologists, hepatologists, and primary care providers. Programs like Survivorship Passport in Europe offer digital records of treatment history and recommended follow-up plans, empowering survivors and their physicians alike. As we arrive at the final chapter of this exploration into liver cancer, it becomes clear that what began as a deep dive into a specific disease has evolved into something larger, a comprehensive reflection on the intricate interdependence of science, society, and the human experience. Liver cancer is not just a biological phenomenon. It is a mirror reflecting the state of global health equity, medical innovation, and our collective will to confront complex problems. Across continents, we see both sobering realities and promising triumphs. In high-income countries, survival rates are improving thanks to better screening protocols, effective antiviral therapies, sophisticated imaging tools, and advanced surgical techniques. Major cancer centers like the Mayo Clinic, Cleveland Clinic, Memorial Sloan Kettering, and MD Anderson are not only treating patients with cutting-edge therapies, but also generating the evidence base that informs global practice. At these institutions, interdisciplinary teams meet regularly in tumor boards, where radiologists, pathologists, surgeons, medical oncologists, hepatologists, and palliative care providers come together to craft individualized treatment plans. Their models of care are the gold standard, and they serve as training grounds for clinicians around the world. Yet these same institutions are increasingly aware of the global responsibility they bear. Many have launched global outreach initiatives, training liver surgeons in Africa, supporting cancer registries in Southeast Asia, or conducting collaborative trials in Latin America. These partnerships acknowledge a fundamental truth, that no medical advancement is complete unless it reaches those who need it most. Knowledge must travel across borders. Compassion must extend beyond walls. At the same time, we must acknowledge the countless smaller clinics, rural hospitals, and community health centers that are waging their own quiet battles against liver cancer. Their resources may be modest, but their impact is profound. In towns and villages far from capital cities, clinicians perform ultrasounds with portable devices, counsel families in local dialects, and dispense life-saving antivirals from refrigerators powered by solar panels. Their ingenuity and resilience embody the essence of medicine, not just as a science, but as a human endeavor. And it is the patient who remains the central character in this story. The person receiving a diagnosis they never expected, enduring treatments that sap their strength, and navigating an uncertain future with courage that defies description. These are the people who give meaning to every lab experiment, every data point, and every policy debate. Their stories are as diverse as the disease itself. There is the elderly man in Tokyo who, after a lifetime of heavy drinking, receives a diagnosis of cirrhosis and liver cancer. With the support of his family and the skilled care of Tokyo University Hospital, he undergoes resection and begins a new chapter of sobriety and advocacy. There is the young mother in Sao Paulo whose hepatitis B went undetected until her second pregnancy, leading to the discovery of a small tumor that was successfully ablated. Now a vocal campaigner for prenatal screening, she tells her story to help others avoid what she endured. There is the farmer in Ethiopia, diagnosed late with advanced HCC due to hepatitis C. Though curative options are out of reach, his care team provides pain relief, emotional support, and spiritual counseling. In his final weeks, he tells his doctor, "You may not have cured me, but you gave me peace." That sentiment, peace, dignity, and understanding, is often as vital as any medical breakthrough. We also hear from the families, spouses who keep meticulous medication schedules, children who bring joy to hospital rooms, and siblings who donate a portion of their liver to save a loved one. Living donor liver transplantation is one of the most extraordinary acts in medicine, and it has changed the trajectory of countless lives. In South Korea, where cultural norms and legal structures support living donation, survival rates after transplant are among the highest in the world. Surgeons like Dr. Sungju Lee at Asan Medical Center have performed thousands of these complex operations, each one a testament to surgical skill and familial love. Survivorship is an area demanding renewed attention. For patients who beat liver cancer, life after treatment often brings a new set of challenges. Managing side effects, facing the risk of recurrence, dealing with emotional trauma, and rebuilding a sense of normalcy. Programs focused on survivorship care planning, mental health support, vocational counseling, and lifestyle coaching are essential to ensuring that patients do not just survive, but thrive. Cancer support groups, often overlooked, provide a lifeline, a place where patients and caregivers can speak freely, laugh, cry, and find community. Looking to the future, the vision is both bold and attainable. Scientists dream of a world where AI detects liver cancer before a single symptom appears, where vaccines prevent most forms of the disease, and where every treatment is tailored to the biology of each patient. Policymakers envision a world where hepatitis is eradicated, where universal health coverage ensures access to care, and where stigma no longer prevents people from seeking help. Clinicians imagine a world where their tools are more precise, their systems more humane, and their patients more empowered. And yet, achieving this vision requires commitment from all of us. Researchers must pursue discovery with integrity and urgency. Clinicians must practice with empathy and skill. Governments must invest in public health infrastructure. Media platforms must combat misinformation and amplify science. And citizens must advocate for themselves, for their families, and for those whose voices go unheard. One of the most inspiring examples of collective action comes from the city of San Francisco, which has implemented a citywide hepatitis B screening and treatment initiative targeting Asian American communities. Coordinated by UCSF, community clinics, and grassroots organizations like the San Francisco Hep B Free Campaign, this initiative combines culturally sensitive education, free testing, and coordinated care pathways. The result? Improved detection rates, reduced stigma, and a decline in liver cancer incidence over time. It proves that when science, policy, and community work in concert, transformation is possible. In the world of liver cancer, such transformation is not a luxury. It is a necessity. The disease remains one of the leading causes of cancer death globally, with millions of lives at stake. But every year, the tools at our disposal grow stronger. Every study adds to our collective wisdom. Every survivor tells a story that inspires others. And every effort, no matter how small, contributes to a greater movement toward healing. As we close this journey, let us remember the patients we've met along the way, not just as subjects of statistics or recipients of care, but as human beings whose courage shines through the darkest moments. Let us remember the doctors, nurses, researchers, and advocates whose work is fueled by passion, perseverance, and purpose. Let us remember that in the face of a disease as formidable as liver cancer, the greatest weapon we have is unity. Unity of purpose, unity of knowledge, unity of compassion. And so, to those currently facing liver cancer, know this: you are not alone. You are supported by a global community of experts, caregivers, survivors, and advocates who stand with you. We will continue to fight for better diagnostics, more effective treatments, accessible care, and ultimately, a cure. Until that day comes, may we all strive to listen more deeply, care more fully, and act more boldly for the good of every life touched by liver cancer. Thank you for watching. If you found this video helpful, don't forget to give it a thumbs up, share it with your friends and family, and most importantly, subscribe to the channel for more simple health tips that make a big difference. And while you're at it, tap the notification bell so you never miss out on our latest content. Thanks for watching, and we'll see you in the next video. Stay healthy and keep smiling.